All right. Good evening, and thank everyone for joining us for a very special episode. It's our first panel ever on the podcast. So thanks for joining us, gentlemen.
We're happy to be here.
We're happy to be here. Thank you for inviting
Glad to
us.
be here.
Absolutely. So just so that our audience understands a little bit more, recently we were all part of an event in my beautiful hometown of Houston, Texas, that was hosted by Dr. Simmons and the Sleep Education Consortium. So there was a lot of information that I learned as an attendee of the event and thought this would be really an amazing opportunity to share it with some of our parents. So that is why we are all here this evening. So Dr. Simmons, would you like to do a little intro about the SEC and the event?
Sure, great. Well, thank you very much. So I'm a neurologist, sleep disorder specialist, and when I first got involved in this field in my fellowship at Stanford University back in 1991, it sort of was very mind-boggling to me that I had gone through all those years of medical school and gone through a highly regarded residency program. And here I was doing my fellowship. And within the first few weeks, I learned so many things that I couldn't believe I didn't already know, because I realized how fundamental they were to overall healthcare.
Mm-hmm.
And amongst these were things that related to breathing and just some of the basics of obstructive breathing. And it was just very mind-boggling. So once I finished, I was in academics, I was involved in teaching, but then I transitioned into the private sector. But I had this underlying desire to help continue to spread the word to other healthcare professionals, because I realized there's a big gap in our healthcare system. Just like I realized that when I first was doing my fellowship, here I was now in private practice, and I realized that so many physicians who are already done with their medical education, they have no method of really getting up to speed to learn what I call our basic truths of overall healthcare and sleep, which really you can consider a nutrient. You can't live without sleep. And there are so many things that can destroy the quality of your sleep. And amongst those, epidemiologically, or in terms of the frequency, the most frequent kinds of problems relate to abnormal breathing during sleep. But I wanted to come up with a course that can be done on an annual basis to teach other healthcare professionals about sleep. And so I started this nonprofit organization back in 2004 called the Sleep Education Consortium. And every year we have a conference to teach healthcare professionals about sleep. And the perspective I had gained to a great extent because of my collaboration with Dr. Rob Veis, who's here joining us tonight. When I was at UCLA, I was educating, and I already realized the airway is going to be influenced by the mouth and the jaw position, and we'll get into more grinding, clenching, and the significance of all that later. But so I wanted this conference to not just be for physicians, but also for dentists. And then I also wanted to have one of the themes about collaboration. So this has been going on. We just had our 20th year of doing this consortium, this annual event, and it's grown in its complexity. It's now actually a 3-day event for dentists, 2 days for physicians. And, we take people that don't know anything, we bring them to where they know quite a bit. They're going to learn more in those 3 days than they would ever have learned in medical school. Because in medical school, unfortunately, medical students over 4 years are learning up to maybe 4 hours of anything related to sleep. That's
still
it.
mind-blowing. And isn't Airway about the same or less?
Well, yeah, that's only a fraction of the 4 hours.
Yeah.
So anyhow, rather than going into great detail on that now, everyone here was at the consortium conference, and I'll just quickly go in introducing other people that are here. So I mentioned Dr. Rob Veis, who is a dentist. He's a CEO of Space Maintainers Laboratory that makes appliances. He's been on the faculty at USC, went to dental school there, and he's been involved in dental education for many, many years, and actually got me involved in helping him put together, back in the 90s, educational materials for dentists. But so he's on the panel here. We have Dr. Bill Harrell. He's an orthodontist who is also involved in academics in Alabama, in the university there, and he's involved actually in helping coming up with new technologies. He was very involved with cone beam CT scans from the early development, and he's on the cusp of new trends of orthodontics. And he was also part of a faculty at the consortium. We got Dr. Dave McCarty. He's an internal medicine sleep specialist living in Colorado Springs.
No, Boulder.
Boulder, Colorado. Oh,
Boulder.
shame on me. Sorry. But previous to that, he was actually running the sleep lab over at LSU in Louisiana. And he trained at Harvard. He's got, he went to medical school, Duke, extensive background. He recently just came out with a book on sleep apnea empowered, and to actually educate healthcare professionals on this topic, and so he's well versed in every aspect of sleep medicine. And then we also have Jatin Tekchandani, who's actually a sleep technologist who he's at the basic ground level, taking care of patients at night. I mean, he's beyond that now, but that's where he started his introduction to sleep, was functioning as a sleep technician, and then also getting an engineering degree and taking his knowledge of engineering and applying it to being a sleep technologist. He's a great educator. He's helped many technologists get their training and become certified. And he's actually currently the vice president of the Texas Society of Sleep Professionals. So he's, a very knowledgeable person and involved in many different aspects of sleep medicine as well. So we're all here. We had much larger faculty at the conference. We had maybe
like
12,
17 people.
Is that 17?
I think
faculty members total. But we have the subset here that I think can handle pretty much most of the questions that would come up regarding the conference. And thank you for having us here. And Rebecca, it's in your hands.
Awesome. Well, thank you very much. And I'll just say that parents had so many questions, and I was fortunate enough to attend all 3 days and even got to bounce around some of the hands-on events, which was really cool. So what I did was, for parents that are interested, I'll make sure there's links to everything, so you can go to everybody's website. You can see their LinkedIn. Many of these gentlemen have been on the show already, so you'll be able to see their podcast. But you can check out the conference. You can see that just so much information was covered. And I just kind of handpicked a few pieces that relate to things that our parents have asked about before. So we're going to start with the fact that, at the conference, we did talk about children and adults, but today we're really just going to focus on kids. So I want to start with, let's first define sleep bruxism in TMJ. I think parents kind of have a basic understanding of that, but let's go ahead and level set with that. And then how does it present in children?
I can start.
Absolutely.
Looking at it from the parents' point of view. I think one of the things that I hear all the time as a practicing dentist is a mom or a dad coming in, usually the mom, saying, I hear my child grinding their teeth at night. Is that normal? This is a good news, bad news question, because the bad news is most of my peers, unfortunately, will say to that parent, well, let me look. And they open the patient's mouth and they look in there, and they may see a little bit of wear on those baby teeth, children's teeth, or in the mixed dentition, they may see a little bit of wear. And particularly when they're still have their baby teeth, their primary dentition, and they'll look at the parent and they'll go, well, don't worry, that's normal. And let me assure you that there's absolutely nothing normal about that.
So there's the idea of what's normal, like the normal variation. Is normal healthy is the question.
It's
the
common.
fact that it's common.
Yeah, common is not
and
normal.
widespread doesn't make it healthy, right?
Exactly.
Right. Yeah.
Exactly. To your point, Dave, it's very common. And the other part that's common is the unfortunate response by dentists who aren't aware of that. And this is why we're here to try to educate the parent. One of the things I'd like to see accomplished today is that if we can give you parents a little bit of knowledge, it's going to spur you on to further ask the dentist and maybe point some of those dentists in the right direction to help them. I mean, I want the parents to help the dentists and any other primary care physician to then help them. I mean, this education has to go all the way. So the first thing that you need to know is it may be common, but it's not particularly healthy. And the only other thing that I want to say right away is one of the things that dentists will do right away in my process of trying to educate you parents there is they'll say one of two things. Well, we'll watch it. One of the things I hate the most, because I'm going to watch you get ill. I'm going to watch your problem get worse. God, I hate that. And then the second thing is, well, let me make you an appliance that will give you a bite plane, something that will stop the teeth from being ground away. And that's what they know. And not only—
And you mean, you're talking like a night guard?
I'm talking more like what would be a retainer, a Holly type retainer that has a biting surface in the front teeth. So it separates the back teeth. And when they close on the front teeth, they can't grind their teeth. They're hitting the bite plane. And that's a common thing that dentists will do because that's what they know.
But the focus is on protecting the teeth, not in figuring out why the teeth are wearing away, right?
Well, they don't even know. Don't even know that it's a sign and symptom of an airway problem, and I'll let Jerry go from there.
Well, so let's just expand the definition now. So grinding, so what is bruxism? So bruxism actually is no longer is considered just the grinding, but also the clenching. So if you're clenching your teeth at night, it's also considered bruxism, sleep bruxism. Now, once that child has that kind of an appliance, they may be protecting their teeth and they may not be moving back and forth, but they're clenching into that appliance. And they're building up all this musculature here, and their joint may be protected because they've opened up the space, so there's not going to be as much pressure right on the joint itself. But there's still a tendency to be clenching. Now, when a child's clenching or grinding, what are they doing? They're keeping their jaw forward, because when they relax, the jaw may be falling back. And that's the problem, is that the airway is prone to obstruction. And so the clenching or the grinding becomes a protective mechanism to help keep the airway open. So it's an abnormal phenomena that's occurring as a reflex to protect the airway.
It helps to sort of point out that this is a symptom of a larger problem, right? This is the body's attempt to compensate for a stressor on the system, right? And so just by protecting the teeth, we're not solving the problem yet. The stressor is still there, in other words. And I think that's we haven't gotten to the root. Is that the grinding of the teeth is just a sign of an internal problem that still needs to be solved, right?
Okay, and so you're saying this, and so what proof do we have? I mean, it's easy for us to say this conceptually, it makes sense, but how do we know? What proof is there? Well, I'll just point you to several studies that have looked at children that have enlarged tonsils and looked at the frequency of bruxing that occurred in these studies, and found that anywhere 25, 35, 40% of those kids were bruxing at night. Okay, then they had their tonsils taken out. All right, and that opened up the obstruction, and then the frequency of bruxing dropped down to 10%. All right, and so their occlusion, people say the bruxing is because the occlusion is off, because the alignment of the teeth are off. But by taking out the tonsils, you're not changing the alignment of the teeth. It's the same. you're getting the improvement because you've opened up the
Your
airway by getting
airway.
rid of the obstruction of the tonsils. Now, getting the tonsils out is not going to resolve the problem in most of these cases indefinitely. It's going to help the problem. It's going to help open up the airway, but usually these children have other aspects of having compromised airways, and maybe it might be several years later that they're going to demonstrate more of the problem. But just the main point to make here, though, is that opening up the airway improves the bruxism. And we now know this also from children that have been diagnosed with diagnosed with sleep apnea, that we've put on CPAP, the mask that hooks up to a tube to a machine. And now CPAP is not the long-term solution. I call it a transitional therapy. So we use it temporarily while orthodontics can be done to open up the airway for long-term management. But the bruxing will stop when we put the child on the CPAP because now their airway is protected.
So one of the things that, I'm sorry, Bill, go ahead.
It's all right, because I'm gonna bring you up into this too, Rob. You know, in dental education, and you probably were the same, Rob, we were taught about bruxism in children, especially in the primary dentition. Like you said, it was kind of considered, well, this is normal. You know, the baby teeth are softer than the permanent teeth, and they just wear like that. And you know, again, what Jerry brought up earlier was, you know, we thought in dentistry that it was all related to, well, the bite's off, and so they're trying to grind their teeth. Well, that's not true. And you know, the problem is in the primary dentition, if you look at the wear pattern from a dentist standpoint, if you look at the wear patterns, it's not that much about side to side, it's front to back, because they're trying to open up the airway. So finally we're getting a little smarter, but dentists are taught that
Right.
you know, the baby teeth are softer and they just wear naturally, and it's a normal thing. But you know, recently, like Jerry brought up, some of these studies have kind of opened our mind a little bit better to the reason why, because these kids aren't, you know, we think about adults doing grinding too, and we say it's stress. You know, it's what's their stress level, unless they're abused or something like that. I mean,
Right.
they don't really have much stress, so it's got to be from something else.
So,
And I think, go ahead.
okay, thank you. What I was going to say is just trying to leave like messages for the parents, like what's the next step for you? So
Yeah.
when we talk about bruxing, it would be number one, pay attention. And, you know, we're always trying to figure out, well, you know, we know that parents will listen for snoring and things like that sometimes because they can actually hear them. But I would say, you know, pay attention to see if your child is bruxing. And then if they are, then you go to your dentist and you say, my child is bruxing. And when the dentist says to you, oh, that's normal, you then have to say, well, look here, I've heard from these doctors that it's really not normal. And let me show you where you can go look. And can you refer me to someone in your area that maybe there's an MD or someone who specializes in sleep that I can have my child evaluated, because it's not normal. And here's the thing, consumers push the curve.
Right.
You know, it's what the
Airway
the
mama
way,
bears. Yeah.
and as you know, one of the things we talk about in collaborative care is how do we push this forward? And the one reason that I wanted to do this more than anything is I want to speak to you parents out there. Have you help us to push it forward? Because it's going to only happen when you start squawking.
So, okay, so
Great.
as a physician,
Great.
so physician, since they hear about going to a conference, and they're going to say, I don't have time. I'm so busy. Why am I going to go to a conference? You know, I work so hard day in, day out, and I don't want to take time off to go to some other conference for a topic that maybe I'm not all that thrilled about. It's not within my specialty. I don't want to do it, you know. But when the parents are saying, here's a problem, and obviously you don't know how to solve my problem with my child, and then the physician then finds out that there is a conference that they can go to learn the answers, then they're going to be more motivated. The more they're going to be challenged during the day by the patients coming to them with a problem, and then they're presented with an opportunity to get the knowledge to deal with that problem, that's what's going to connect
That's
the
when
two.
change is going to.
And
And I
that's
will say,
right.
we'll put links in the show notes, but for example, the SEC conference and Airway Health Solutions, they both have a great video series that we can put out that you guys can obtain. So maybe you can't get away to go to some of these events. There are options. We also have an area of our website that parents can send clinicians to, called the Clinicians Corner, and we are building on that to make that more robust. And it's because of people like you. It's your information we're putting there. So there are places you can at least send them to start looking. But I want to touch back with Bill for just a moment, because in your podcast, one of the things we talked about was TMJ. And, we kind of made this connection, and I just want to make sure that we address it here as well for anyone that didn't hear it, about bruxism and TMJ, but more specifically, kind of to Rob's point, you can hear them snoring. You can't always hear these other things, but there are signs and symptoms as parents that we can look for.
And let's define that also a little bit. So TMJ,
Yeah.
temporomandibular joint, but it's really TMD, temporomandibular dysfunction, or TMJ dysfunction. So everyone has a T, but Rebecca, you're just demonstrating what the lingo, how it's evolved.
Yeah, how we hear it as parents.
Right.
Yeah.
TMJ, everyone has a temporomandibular joint. It's just it's the dysfunction. So TMD is probably but go ahead. Sorry.
What it should be. Yep. No. That's why you're here.
It's a good clarification. And oh, by the way, you have two of them.
And they
Right.
both move.
Right. It's not just one
Can't
side.
move
They're
one
all.
without the other.
And they need to
Very
work
complicated.
together.
Yep, exactly.
So
So
can we
Bill-
talk a little bit about the signs and symptoms that parents can look for?
Yeah, and in children, maybe things don't show up because you think about TMJ disorders, you think about arthritis and some of the destruction that occurs in the joint. Inside the joint is a little cartilaginous cap that sits on top of the bone of the lower jaw, and that's called the articular disc. It moves as you open your mouth. Your jaws just don't rotate; they actually come down a slope. So the jaw actually, as it opens, it starts to rotate, and then it actually translates down. And what keeps it in congruency, so to speak, is that little piece of cartilage. I kind of tell parents it's like a piece of cartilage in a chicken leg. They can kind of. It's not exactly like that, but they at least know what that bristly thing is. But that is interposed between the bones, and believe it or not, it can become displaced even in children. And I saw a seminar just last week where the orthodontist, he was taking MRIs on all his children, and he was finding a fair number of them, their discs were displaced. Now I worked with Dr. Bill Farah, who was one of the pioneers in TMJ a long time ago, especially in adults. But and we saw some kids. I see some as early as 9 years old that maybe their bite is looking something like that, and it's trapping the lower jaw, and it actually the jaw actually gets displaced posterior backwards, and the disc comes forward. So if your child has clicking and popping, you can actually put your fingers in front of their ears and have them open and close and go side to side. It should be smooth. They should be able to open. The normal opening is about 3 finger widths of your non-dominant hand. If you just kind of want a quick little biometric measurement, if you take their fingers, non-dominant hand, you should be able to put it easily between your teeth, and you should have no clicking, popping, or locking. But if you have 2 finger widths, then it could be muscular. It could be that the internal parts of the joint are actually not functioning properly. So a bite like this is terrible on a jaw joint. Now, parents will look at that and say, well, their teeth crooked a little bit, but they really don't look. If you look at that case, you can see where you don't see any lower teeth at all.
Mhm.
They're biting up, number one, in the roof of the mouth, which is not healthy. But think about them trying to move their jaw forward. What happens? They can't really, they're locked in. And
Right.
the TMJs are locked, and sometimes they're sitting backwards and they're off these discs, and they develop that way. Then all of a sudden they get to be at orthodontic age, and then you put braces on these kids and line the teeth up and make them look pretty, but their discs may be totally out of place. And it really, the problems don't show up until their 20s or 30s or 40s, when they may be starting getting locking. They end up having to have surgery and all sorts of other stuff. So between sleep disorders in children and then, early signs of TMJ disorders, those are really important. It's important for parents to understand that and try to look for things. And if you go to the dentist and say, hey, my kid's jaws are clicking and popping, or they're locking, and they go, that's just normal, they'll grow out of it. No, they don't.
Right.
This watchful waiting, like Rob said, is sometimes it's not good, because it leads to more serious things and more
Right.
complicated treatment
So-
later down the road.
Right, absolutely. And I also want to touch on something that was interesting that you said, and I've heard, Ben Moralia has said this, Felix Liao. Y'all aren't teeth doctors, you're mouth doctors, and that to me is another paradigm shift that needs to happen, because
Yep.
straight teeth, that's awesome, but straight teeth with everything else messed up, there's no point.
I wrote an article for the Dental Sleep Practice Journal called The Breathing Smile Connection. And
I'll
it
put a
goes
link in there.
into the introduction is kind of how orthodontics kind of has pushed itself toward smile aesthetics and pretty smiles and pretty faces. And okay, we create healthy gums and we create those kind of things. And theoretically, we've been taught that if we can get the bite into what's called class 1, or a normal relationship of the teeth, then they're not supposed to have TMJ problems, and they're not supposed to have airway problems. Well, guess what? That's not true.
Right.
And that's kind of why I wrote that article, because it's the breathing, the airway, it is critical, and airway and jaw joint problems all go together.
Mhm.
So Rebecca, I shared my screen. I don't know if you see it.
Nope. Right now we see,
It says you are shared.
See the class 2 division 2.
Yeah,
Is
you
that
seeing
you?
that?
Oh, okay,
That's
that's
me.
you. I thought Dr. Harrell did that. Okay.
I know, I
Yes, we
did
do see
that.
that.
So,
Okay, yeah.
again, kind of showing what a parent might see. If you have a child who has what we would describe this as a very deep bite, you can't see the lower teeth at all. And if you can't see the lower teeth at all, that means that the mandible is being held in a posterior position. It takes those condyles that Dr. Simmons talked about, that TMJ, and holds it up and back. And that's the beginning of the problem, in a young kid. So for mom and dad, if you see your child and they have a deep bite like this, that's something you need to be concerned about. Okay. And, that's one of the things that I would tell you to see. And see if I can just quickly go back here. Hopefully I can show you. I can't. I'll find it and pop it in for them to see it later on when they're looking at this. Okay, because
Okay.
I don't want to disrupt the talk, but I will include a couple of slides for the presentation for this so that they can pull it into your thing. But it basically
How's
is,
that?
what does the face look like? Okay, that's the key. What does the parent see in terms of their facial profile? What does it look with their dentition? What are some of the key things? Are
But
they
I think,
thumb suckers? We'll
Right.
show you some things that parents should really look at, which then could go to one of the things that Jerry should address, because I see popped in here. It's like, how can we teach the parents to screen their own kids?
right.
Mm.
But I mean, there's so much, and some of the detail that we've just conveyed here may be a little bit beyond what the parent may be able to pick up. But it's a big picture. There's a spectrum to the degree of the problem. And look, I don't know that it's appropriate for us to put out information with the expectation that the most subtlest kids that are the ones that are most mildly affected are going to be captured by the information we can hear. I think let's go up to the bigger picture of those children that are more seriously affected. So if the child, let's say, tosses and turns all night long, they're just not or they're hard to wake up in the morning, and they're throwing the sheets are off the bed, they can't focus in school.
Yeah.
And they're always talking out of turn, and they're hyperactive, and they're a real problem. Behaviorally, they're a problem. And then you see that there's these issues with their teeth. They're clenching, they're grinding, their mouth breathing. Okay, the pathway of least resistance should be through the nose. So if a child's not getting the air that they need through the nose, they're going to compensate and do what we call rescue breathing. They're going to open their mouth and they're going to start breathing through their mouth. They may be drooling on their pillow at night. When you see a child like that, if you have a child like that, and you go to now we're not talking about just a little problem that I'm noticing that their bite is deep. And if that's the only problem and your child sleeps really well and they're behaviorally doing well and they're well rested and nothing else a problem, you're not going to get too many people to take that too seriously. And yes, it may be a problem, and maybe anatomically they are predisposed to other issues and may become a problem later in life. But let's get to the bigger, more serious scenario when your child is having these other symptoms I've talked about, and you go to your dentist or you go to your pediatrician and they disregard your concern, you've got to go somewhere else.
Yep. And
But
we'll put some links, by the way, within the show notes as well.
Right.
You can find providers.
And I want to prepare the parents for the scenario here, and then I'm going to segue here in a second, because then you might actually get a clinician that's going to say, okay, I take you seriously. Let me order a sleep study. And then they're going to send you to a lab, and your child may be, let's say, 7 or 8 years old, and the lab will do the study, and it comes back saying no significant problem. So I'm going to let Jatin now talk a little bit about that, about what goes on with these tests and how it could be all over the map. And do you trust a test that comes back normal when clinically you've got a gut feeling my child's got a problem? So Jatin, maybe you could talk a little bit more about the testing aspect.
Sure. Thank you, Dr. Simmons. So we've heard a lot of discussion today about sleep disorders. In previous episodes, we heard from Dr. Simmons as well as Dr. McCarty about a few things like sleep staging, REM, non-REM, deep sleep. We heard from Dr. McCarty about the AHI. It's very important that these numbers come from what Dr. Simmons just mentioned, is a sleep study. So what is a sleep study? To get these things, you have to measure multiple things. Measure brainwave activity, eye movement, airflow, effort, leg movements, and oximetry. When you gather all of these different things, these are multiple sleep graphs. Multiple sleep graphs translates to polysomnography. It's one of the most comprehensive medical tests you can do. It requires no blood, no radiation, and you spend overnight. Similar to a hotel stay, you will check in and check out. You will be given snacks and drinks. You will spend more time with the person performing that test, the sleep technologist, than you will ever spend with the physician for a period of time. And during the application of these sensors, which can take up to an hour, half hour to an hour, depending on the experience level and the cooperation of the patient, you're going to get educated by the technician. As each wire is applied, they're going to explain to you this wire is applied and what the reason is for it, and how it relates to the end result and what we're going to do about it as well. Dr. Simmons also mentioned CPAP therapy, continuous positive airway pressure. Whenever the doctor prescribes CPAP, it's based off what's called a CPAP titration, where the technician applies a small amount of pressure and then slowly increases and increases and increases it until we get an open airway. So we're talking about sleep. You can't manage sleep until you can measure sleep. If you haven't done a PSG is what it's called, then we should do one. And even if you have done one, it may be time to do another one, because you can't really know if you're sleeping or if you're not, or if you're breathing or if you're not, unless you are measuring it. And for a pediatric population, there is no other alternative than an in-lab PSG.
And how does that work, as far as some of these kids are little, it's scary, and totally get that. So just kind of, so to level set it for parents, do they stay with the child? Is the child in a different room? How does this process work?
So the parents will always be in the same room. They may or not be in the same bed. There will be rails to prevent the baby from falling off. In some situations, they even have cribs. So what you would do is you would confirm all of this when you schedule the test. You will schedule, you'll have the age, you'll have all the issues. And there's also pediatric focused technologists. And there's even pediatric focused labs and even hospitals. We're going to have another guest on the podcast coming up soon, James Cardell of the Lucille Packard Children's Hospital, and they do nothing but pediatrics. So he'll be able to explain a lot more about the actual logistics of getting that test and getting the instructions for our parents. What James and I work on is another collaboration, just like Dr. Simmons is collaborating with dentists and physicians. What we're doing is collaborating between the technologists and the engineers, because the engineers are developing the systems, but they may not understand quite how they actually are put into practice. And the technologists are having issues with these problems, but they can't communicate with engineers. So that's what we're going to try to focus on now, is try to get this collaborative idea from the SEC and translate it to this other aspect as
well. Yeah, and oh, go ahead,
So
Dr. Simmons.
Jatin, what would you say about a scenario where the child has all these symptoms, but the lab comes back with the test being normal? I guess let's talk about, well, theoretically, every lab should do everything perfectly. But the reality, my experience, is that a lot of times the labs aren't up to par to where we would like them to be. They're going to pick up the clearly abnormal kids where their oxygen levels dropping down. Those are easy to find. But when you get these more subtle cases, how,
right.
And a lot of labs may not have as much experience with kids, but all of a sudden they're going to do one here and there. And
so it's important to remember that there's two technologists. One is the person that's applying the leads, that's the acquisition technologist. And what Dr. Simmons is talking about is the second person. The second person is called the scoring technologist. Whenever they look at the signals, we have to make a classification. After you decide whether the patient's asleep or awake, if they're REM or not, you classify whether that event qualifies as a respiratory event. So there's clear-cut criteria. And what we're talking about is a desaturation as one type. We call that the AASM. There's also one that causes an arousal. The D4% desaturation is the Medicare definition, and the 3% or arousal is the American Academy of Sleep Medicine. So the technician on the daytime, the one scoring the study, also has a very significant impact on the result. Because if they decide not to score that study or not to score that event, then the patient will test negative. Versus if they use a different criteria, using a different sensor, they might test positive. And with the pediatric population, the difference is 1 per hour. As long as you have one event per hour, they are now diagnosed. So if you fail to miss one of those events, now your AHI, the apnea index is less than 1, it's 0.9 or something lower. Now you have a negative study. So what Dr. Simmons is saying is you can have a negative study and still have a problem, just based off of how the study was conducted and how, more importantly, the study was scored. There are also different quality sensors. As the engineer putting these systems together, including the one at Dr. Simmons, we had to calibrate those sensors. If the calibration was off or the technician applied it incorrectly, the scoring technician wouldn't be able to even score these events. So the scoring technician and the acquisition technician have a severe impact on the end result of it. If you go on Tuesday versus Wednesday and the technician is a different person, you may have a different result. It does have that much of an impact, as well as managing the actual situation. Pediatric patients are the most challenging. They're not cooperating because they don't know what's going on. So a skilled technician will make the patient feel comfortable and also the parent comfortable. And there are many times where we're testing the pediatric population, the children, and we uncover a sleep disorder with the parent. We see them snoring, gasping, having apnea. It's like, actually, maybe you're the one that needs to get this study. So we have to just kind of navigate that situation as well. But the technician isn't a doctor. We can't diagnose. We can't recommend treatment. All we're there to do is just to apply the leads and generate these tables and generate these plots for the doctor to make a decision. But the doctor can only make a decision if the technician and the lab do the job correctly. And that's what Dr. Simmons is saying, is that the technician could get this done wrong. It's very easy to miss an event. It's very easy to misapply a lead or just put it 1 centimeter to the left side, and you won't pick up these arousals.
And also, I guess what I'm saying is go with your gut and don't always feel that maybe you're crazy because the test didn't come up with the abnormal result. Not all sleep labs have been created equal. And I use an analogy asking women, are all beauticians the same? You know, I'll say, are all dentists the same? Well, don't assume that all sleep labs are the same.
Right.
You know, so
Right.
if you clinically see your child has a problem and it seems to be related to sleep, you're looking for confirmation from the sleep lab. And if you don't get it, recognize the possibility that the lab just may have missed the diagnosis and you may want to go to some other facility. You might have to travel further away.
Another way to look at this is that the AHI is a language that has evolved differently. And so every AHI must be unpacked. And I think if every parent sort of accepts that the AHI you get on your study, there is a lot of investigation that goes into what that metric is, how it was defined, you know, whether it was defined by desaturations or arousals. And so every AHI must be unpacked is a good mantra for us to repeat, you know?
Yeah. I like that. And you also mentioned something in one of your earlier podcasts, which we'll put a link to also, where you talk about also its perception. The story you tell as an adult, but I think it applies to children as well. You know, this person didn't understand why they were having to come see you and do a sleep study, and I'm fine. Kids are the same way. You think as a parent, you put them down, they were in there for 8 hours, we're good, we slept. But how did they really sleep? Right? You got to get to that core. What are they like when they wake up? There's a lot of things that as parents we can look for. So kind of, I guess, to build on that, what does good sleep hygiene or I'm trying to remember another phrase instead of sleep hygiene, but what does that look like for a child? What should it be, the various stages, toddler, that kind of middle group, 5 to 10, and then up? What should it look like?
Oh, I can do that, Dave. Also, can pitch in, but basically your sleep need changes as you're growing, right? And like a little infant is going to sleep, the newborn's going to sleep most of the day. And then that sleep requirement is going to get down lower and lower. But still, I think the biggest problem is probably in adolescence. And when these children are, needing to sleep, maybe 10 hours, they're probably maybe are getting 7 because they're staying up late at night. There's the after school activities, and then they have homework. And now, in order to get to school on time, they're waking up really early. Because
their
we're living
phones, their iPads,
their phones, and so so there are a lot of children that are sleep deprived. And we're talking about airway as being a cause for ADHD in children, but just something more basic of being sleep deprived can cause ADHD symptoms in children. So if you're going to take your child to a clinician who's then going to say, oh, your child's got ADHD, and they're ready to pull out a prescription pad and write a prescription for a child, and they don't even ask a history about sleep, run, go somewhere else.
Yeah.
If they don't ask, they need to ask these basic questions about, normal hygiene, that, sleep hygiene, and get a better understanding of the child's behaviors. And how much sleep are they getting? What's the environment of their sleep? Their sleep environment. Is it loud? Is their bedroom right next to the street light, and they get the light blaring in, or do they have the parents up in the next room with their TV blaring late at night?
Well, what about inner city kids when they're hearing? I mean, this is a public health issue that I don't think we talk about. They're hearing all of these sounds outside.
So sleep deprivation is going to result in difficulty with focus during the day and hyperactivity. But then you could start looking at physiologic abnormalities, and obstructive breathing would be number 1. And another thing called restless leg syndrome, or another thing called periodic leg movements of sleep, either with restless leg syndrome symptoms or even without, just periodic leg movements of sleep. That's number 2. From a physiologic standpoint, is the next most common cause of disrupted sleep that can lead to daytime disturbances of ADHD kind of behaviors and difficulty with inattention. So if your child has these kicking movements while they're asleep and they're kicking the sheets off, or if you've ever slept in bed with them and they're just having these kicking movements, that's an abnormality. And the child may actually have a low iron level as one of the contributing factors. I mean, there's a lot of discussion. I'm going to, not to take up I know Dr. McCarty knows this stuff really well. I'm going to actually transition to give him a chance to speak on the topic as well and give.
And I want to make sure we talk about RLS, because I will tell you, even with everything that I've done, I sat in that conference, and when we started talking about it, I was stunned when somebody said something about children. I thought, seriously?
Oh yeah.
It never occurred to me. Oh wait, so the little monkeys is what we used to call them, because they would turn upside down in bed and their little legs are going everywhere. It never occurred to me, oh, that's a restless leg, so they actually have it as well. That's not, again, not normal.
Yeah, so it's a very common problem, and it's got a bimodal population distribution. So it happens in young children and it happens in seniors. And the reason is because of the relationship with iron. And it happens that growth is an iron consumptive phenomenon. And when we consume iron, we can develop problems with iron transport to the brain. And when that happens, it leads to these physical symptoms. And in the old days, we used to call them growing pains, you know. And nowadays we sort of recognize there's this relationship with this semi-movement disorder that has to do with a physical sensation of discomfort. So it is, in a sense, a chronic pain sort of issue. If you think about it, it's a chronic discomfort syndrome that interrupts sleep. And when we realize that it's something that has no physical signs or symptoms that you can actually demonstrate, you realize that this is something we have to have a high index of suspicion for, you know. So in kids, this is a very real phenomenon, and as Jerry says, we need to be thinking about this as a source of sleep disruption. And actually, there is a bidirectional relationship between restless leg syndrome and sleep apnea. So it turns out that oxygen transport in the central nervous system is iron dependent. And so if you have regional iron transport deficiency, you cannot get oxygen to critical places in the brain. So the fact that you have restless leg syndrome indicates that you cannot transmit oxygen to the brain. And if you cross that with obstructive sleep apnea, you recognize there's a problem. You know, if you're having oxygen desaturating events in the setting of a problem that eliminates oxygen transports to the brain, you've got a problem that now is augmented by each other. You know, so these problems tend to coexist, and this complexity is something we should all be talking about. You know.
Yeah, absolutely. Another thing that was mentioned along with RLS, and then we've talked a little bit about ADHD, is parasomnias. I would like to just kind of dig into what that is a little bit and how it applies to children, because again, that one surprised me. And then sleep-related eating disorders. So could we touch a little bit on what these are and how
Jerry, do you want to take
Okay.
on the parasomnias?
Okay, I'll take on the parasomnia.
Because we could go into the sleep-related eating disorders with respect to restless legs as well, because that coexists as well.
Yeah, so basically parasomnia is basically our abnormal events during sleep behaviors. So it's when you have some kind of abnormal behavior during sleep, like sleepwalking, sleep talking would be the most common. So if your child does that once, okay, put them back to bed. Don't worry about it. Don't lose sleep over it.
No
But
pun
do it
intended.
twice. Don't worry about it. Put it back to bed. Don't lose sleep over it. But when your child starts doing it regularly and it's going on for at least 6 months now, you definitely want to seek out attention. So it's common for
Especially
a
if
child.
people are getting hurt, right, Jerry?
Well, yeah.
If there's
especially.
injury involved, you should get involved earlier.
But the thing is, it's common for a child to have a parasomnic event, to have, as an isolated event.
And you're
And
talking
so-
like they sit up and talk. They come, you walk in and they sit
Or
up
they
and talk to you
walk
in bed and they don't
downstairs
remember it
and
and then they
they're
go back to
confused.
sleep.
Oh, they walked out,
or
so they
something.
took they took a leak in the closet, all right, thinking it was the bathroom, and they went to bed.
Bathroom.
But it's an isolated event. It doesn't happen very other times. All right. So do you need to get, go to the pediatrician and get a whole thing, a workup for it? It's, if it's a single event, it happens as
Then
kids grow up. All right. And typically what's happening is when a person is in what we call slow wave sleep, not REM sleep. It's where there's these high slow wave phenomena going on in the brain waves that we measure. It's hard to fully awaken when you're in that stage of sleep. But if some kind of stimulus occurs that would otherwise have woken you up, the brain doesn't want to wake up when it's in slow wave sleep. So it goes into this in-between stage of this, pseudo quasi state.
So you're talking
between-
about sleep disruptive forces, and this could be sleep disruptive breathing, and
well,
it could be,
so that's what I was going to say.
and it could be restless leg syndrome too. So,
right, but
so
if it happens
yes.
on an isolated event, it could just be, whatever, a loud noise or
a dog barked outside, right?
or
Yes.
or the child's got a cold and they're congested and they do have obstructed breathing, but it's only on that one night,
Yeah.
right?
Got it.
But when it starts occurring on a regular basis, it may be a sign of obstructed breathing during sleep. It may be a sign of rest or periodic leg movements of
Yep.
sleep. So those leg movements, instead of causing a complete awakening when it occurs in slow wave sleep, the child's now in this quasi state. And this is not just for children, this could be for adults as well. But then they'll start carrying out some behavior and start doing some abnormalities. Now, there's something called a night terror. Okay.
Mhm.
Now, a night terror is not the same as a nightmare. Nightmare is a bad dream, and you're not
Okay.
moving. Someone's having a nightmare. You look at them; they're asleep. You don't know that they're having a nightmare. A night terror, the child's gonna be yelling and screaming and moving around, and the nightmare is in REM sleep, rapid eye movement sleep. A night terror is usually in non-REM sleep, right? And the night terror is going to be it could be a sign of another abnormality. Now, it could also be a sign of post-traumatic stress disorder. All these non-REM parasomnias can be a sign of, and not to alarm you patients, but this is the way my approach to these is that I'm looking for a physiologic cause. And if I can't find a physiologic cause on a child that's having these parasomnias on a regular basis, then I got to start looking at psychological causes.
Right.
And I think about the most common would be abuse.
Mhm.
And it could be part of a post-traumatic stress phenomena. But you don't lead with that. I'm not going to right away start making accusations or start probing
Sure.
into could this child be abused. My job is to first exclude all of the physiologic possibilities. And when I can't find any, and this child's still having it, then I need to now probe further with the parents about the possibility that maybe this child's being abused. And it happens. So
Right.
so that's sort of the topic, I mean, it's a big topic. We could spend the next 2 hours talking about parasomnias. And then there's something
Yeah.
called REM behavior disorder, but that's not common in children at all. It does occur
Okay.
very rarely. So I don't really want to go down the REM behavior disorder pathway of discussion. But the non-REM parasomnias are common. And the first thing we have to look at is obstructive breathing during sleep, if it's going to be a reoccurrent phenomenon, because that's the most likely cause. And if the same child is grinding, clenching, and drooling on their pillow, their mouth, either their mouth breathing or they're clenching and grinding. So
Okay. Okay. Oh, everybody moved around. Jatin, do you want to?
So it's important. Right. So part of the sleep study, in addition to all the sensors we mentioned, the EEG, brainwave, respiratory SpO2, we're also full-time measuring audio and video. So if there was a abnormal situation like a sleep terror or a sleepwalking event, the technician would actually be able to zoom in, move the camera, capture the audio. In addition to having all of the observations from the data, the most important data set is going to be the actual observation of the technician. They are typing in whatever they're observing. So we can go back to that individual frame of that individual video, look at everything, including the EEG, because we're going to see on the EEG the patient was in slow wave sleep, like Dr. Simmons is suspecting. Or we might even see spikes, waves. This will indicate some kind of epilepsy. But this is all only able to be done by the doctor if the technician manages the study the right way.
Okay. Got it. Got it. So,
well, I guess one other thing just to add to that
Yeah.
is at the ability to identify seizures during a sleep study is going to be more likely to occur if there is the addition to a full set of electrodes to perform a complete electroencephalogram throughout the night. Most sleep studies only consist of several different, maybe 6 different electrodes on the head. I'm looking at frontal, central, maybe occipital activity, and seizures are most commonly going to occur over the temporal lobe. All right, and you'll miss temporal lobe seizures unless the study is ordered in a fashion to capture that. So clinically, one thing that's different about our facility is we are not a testing facility. We do sleep studies all the time. We test all the time, but we don't just do the test. We don't take in referrals from other doctors that just, like a primary care doctor is going to refer for us to do the sleep study, and that's it. And we then take the results and send it back. No, we want to see the patient clinically. We're going to take a history. We want to know what's going on with the patient so that way we order the right test. And we want to be responsible for the results of the test to be involved with the treatment plan. So we're a comprehensive entity. And and some doctors they just want to send just for the test. And if a doctor knows sleep really well and they contact me, I'm fine with that. But what I'm not fine with would be the primary care doctor that doesn't know sleep very well and just looks at our facility as being nothing but a sleep test. And in their mind, they don't even understand sleep as a specialty. They understand it.
Right.
Sleep medicine it's just a test. And now that what's in the lab is now just with a home study. So now you don't even have to send them to the lab. All you have to do is the home study. And if the home study comes back negative, you've excluded the problem. That is so far from the truth because the sensitivity of the home study is not as good as the sensitivity of an in-lab study that's done properly. But unfortunately, the mentality has evolved within primary care. They think that all you need now is a home sleep testing device. And so they're just doing it and they're sending the results to some sleep specialist that's going to review it and sign their name on it. And they think that they've done a good job because they had a sleep specialist reviewing it. And when the study comes back negative and they have a patient with clinical symptoms, there has to be a further investigation done.
Yeah, it's a disservice. It's not done
So
completely.
Jerry, could you just clarify for the parents out there, the availability of home sleep studies for children?
Okay, so that's a point that's in transition right now. It's been the standpoint of the American Academy of Sleep Medicine that there are pediatrics. For pediatrics, you have to do in-lab studies. And most home studies have not been approved for pediatric use. There are a few devices now that have been approved, which is fine. I think it's totally okay to do a home study on a child. If it comes back positive, you've now established the diagnosis. The likelihood of having a false positive home study showing sleep apnea, false positive, is very low. The likelihood of it being false negative, meaning it's negative, but the child really does have sleep apnea, is pretty high. In other words, so if the study cannot provide what you need to take a deeper dive. So I'm more concerned about the overall treatment pathway or assessment pathway than say, should you never do sleep studies in children? Well, if in your community, there's a 6-month waiting list and your child's not breathing at night and you see it night after night, you're going to wait 6 months or you're going to put them on a home study, which might even consist of just a ring, right? And it's going to come back positive. Boom, you've just shaved 6 months off of establishing the diagnosis. Now you can talk about treating the child. So I don't want to take the dogma and say you should never do home studies on children. You just have to know what kind of study you're doing and what's the limitation of the technology that you're using. Because if it cannot give you the answer you are looking for, you have to take a deeper dive. That to me is a bigger issue. So
you just
I
made
want to do a follow-up because I've got one coming up with Jatin where we're going to talk a little bit more about sleep, but I want to make sure that we do one with you as well, Dr. Simmons, because there's a whole lot to unpack here, and I think parents need to hear it. But for the sake of time, I want to make sure that we cover our last couple of questions, because I really want everyone to have the opportunity to weigh in on these.
Rebecca, there's one
Yeah, yeah.
one important point between PSG in lab versus in-home testing. We've been furnishing it in-home testing. Those in-home tests are not really true sleep tests. They're just sleep apnea tests. We discussed
Right.
REM behavior disorder, parasomnias, slow wave sleep,
They
REM.
won't pick any of those up.
They won't pick up anything. They'll pick up only one thing, that is either you're breathing or you're not. That's it, right? If you
That's
have
good. Yeah.
a strong suspicion of sleep apnea, fine. We'll get an AHI. The AHI will likely be okay if it's moderate to severe. But if it's too mild, it won't pick it up. If it's anything other than sleep apnea, it won't pick it up, because when you look at home sleep testing, you say it this way: HSAT, home sleep apnea testing. Only one indication you can use it for.
That's excellent clarification. Thank you. Thanks. And again, we'll dive into that more, when you and I have a chance to follow up. But one of the things that was discussed at the SEC, and I know, and I'll put links for any physicians, medical allied professionals that are listening that hasn't attended, the AAPMD has something coming up called Collaboration Cures. But that word collaboration is huge. And I didn't realize how touchy it could be for some people, but it just, I don't understand why it's not quite as well received, because when you're looking at a child, instead of siloing it, if you're working collaboratively with a myofunctional therapist and an ENT and the pediatrician and the dentist, there's so much more, just this comprehensive health we can provide for this child. So I realize this is a loaded question and it is a opinion only question, but how do we make this paradigm shift? What is it going to take to go from siloed to collaborative approaches?
I'd like to address that.
Yeah.
We need a common language. We need to be able to talk to each other in a language that favors the patient. And that's what I've been spending my career trying to do, is to try to find a way to talk about this problem in a way that involves everyone, that doesn't somehow this problem has evolved in a divergent evolution of language where the different silos can no longer speak to each other, and the patient who finds themselves between silos, woe be to them, So if we can have a language that we all can share, that somehow talks about the patient's own experience in this phenomenon, and all of us can share that's where we need to go.
I would add, as a practicing dentist, that and someone who's been treating sleep patients since the 90s, I have just found that I cannot be successful to the degree that I want to be without collaborating. And what I have done is I just tell my patients that I can't really treat them unless they are going to collaborate with my medical partner in this, because I'm just not going to have a chance to be successful. And it really just comes down to that. And what that means for me as a practitioner is some patients are not going to see me because they want that quick fix. They want that dental appliance because they've convinced themselves that they can't wear CPAP or whatever it is that they've convinced themselves of. And so they're looking for that person to fix them, but I can't be that person. And it doesn't mean that I won't refer them to somebody else who might fulfill their need, but it's not going to be me, because I want to have a fighting chance to be successful at helping them. So part of the cure is education and experience. And I use myself as the example that over time, I hope that I'm getting better and better at how I treat my patients. And it's changing how I treat my patients. The other part of the cure are things that we're doing here, Rebecca, and I'll repeat what I said at the beginning, which is the change really, in my opinion, come from being patient-driven. parent driven. That's why any good product, whether in the dental field, like aligners, do you think that aligner therapy was driven by the dentists? No, it's driven by patient needs, by these companies that went out to them and said, hey, we can make your teeth straight, and go find someone who can do that. And it's the same thing. We need to educate the parents, educate the end user, and push them to push us to communicate with each other. I think they have to be demanding to want that care.
Rick,
You're
You're muted,
speakers
Dave.
off.
You're
Dave.
muted. Dave,
Dave, your
Dave,
speakers
Dave,
off.
Dave, you're muted. You're
Dave,
muted.
you're
Dave,
muted.
you're muted. We can't hear you.
I would say push us to communicate with each other. That is so true.
See, one of the things, if you look on TV now, there's all these big ads about Inspire, and they have some
Mhm.
great ads. They got some of the other people
Oh, yeah.
wearing masks, and then this one guy over there says, "I have Inspire." Somehow, the American Academy of Dental Sleep Medicine or something, we need to put some ads out there like that. Now, it's very expensive, and that's how Inspire can do it, because they're a big company and they got a big budget. But that grabs their attention, and I guarantee you that gets people to say, I don't want to wear it. I want to go see if I'm a candidate for Inspire. And
Yeah.
a lot of them, maybe some of them are, but a lot of them aren't, because they got to get scoped and all this other stuff.
Mm-hmm.
But if there was an ad campaign or something along with that to say, well, here's another alternative, but I don't know if we have a big enough group to be able to go out there and afford some ad campaign like that. I don't
Yeah.
know. I wish we did. I thought
Yeah.
about it. I just saw the ad on TV just an hour ago.
Oh, yeah. And it
do
said,
something
you
like
said
that.
Inspire, and now the whole thing is going through my head. It's Inspire, Sheila. I can do the whole commercial. So
Yeah,
it
do the whole
works.
commercial. Yeah.
I don't even
But
need it.
it's
It
not,
works.
but it's not as simple as the commercial. Patients think, oh, they don't even realize it's an implantable device. They think there's
Yeah.
something that you just press right
I
here in
had
your
to
chest.
I had to look it up to find out what it was. But
Yeah.
Right.
to his point, because it was there, I went and looked it up because I'm thinking, what is
Yep.
she yelling at Sheila for? What is she talking about? And then I went and looked
Yep.
up what it was, and now I know.
Well, just like Dr. V said, he can't function his best without having, physicians. I know that I need dentists to collaborate with. When I first relocated from California, I was in faculty at UCLA. When I came out to Texas, I was looking for, a dentist, at least one that I could work with locally, because I knew that I had to provide appliances for patients to stabilize the mandible. Even a lot of my patients that are on the CPAP, they'll do better if they're on an appliance. But I already recognized that it's part of the treatment pathway. So I went on my way to find someone to fit the niche.
Mhm.
And the person I collaborated the most with was Dr. Ron Preen, who's also one of the faculty members at the consortium.
He was there. Yeah.
And he didn't know, when I first met him, he didn't know anything about sleep. He was a TMJ dysfunction dentist, but he was making appliances. So I then taught him a little bit, and he right away was like a sponge and learned a lot. And he's a big educator now in the field. But this was like back in 2001, 2002 when I first met him. So part of the problem though with collaboration is we're all these doctors are busy doing their own thing, and they don't necessarily reach out. They're going to do what their piece of the puzzle, and there's not a good quarterback to really pull these patients together. So if you look on a national level and see where are things changing the most, I think what you're going to find is that there's a new type of clinician called a myofunctional therapist.
Yep.
And the myofunctional therapists are basically physical therapists of the mouth, of the airway.
Mm-hmm.
And they are either coming through the pathway as being speech pathologists that then realize what myofunctional therapy is and they get on board that way, or they're dental hygienists and they're looking at mouths all day long and they become empowered by learning what's going on with myofunctional therapy, and then they go into that professionally. But these myofunctional therapists in many instances are functioning as the quarterbacks.
I was about to say that on the podcast. That's what I hear over and over.
Right. And
we're
they
the
are,
and we're just coordinating and sending patients.
and they're right. So they're almost like the care coordinator, because they can't function on their own. They need these different kind of clinicians, and they're getting it, and they're working with the dentist and the sleep physician, and the ENT doctor. And so they're functioning and evolving to help fill this void. Now, in my practice, I mean, I have 5 nurse practitioners. All my patients are seen by my nurse practitioners, or otherwise I'd be the bottleneck of my practice. So and I'm behind the scenes working with my nurse practitioners, and I see a lot of the patients, but I don't see every patient. So I couldn't. There's not enough time in the day. We don't rely on the myofunctional therapists in my practice to be the quarterbacks, because we're at a level that we know how to do this, and we don't need the quarterbacking. We send a myofunctional therapist quite regularly to a month, and not to 1 or 2, to many, depending on the geographical area, or we're getting referrals from myofunctional therapists, and then we're referring back. But most practices aren't going to be like mine, and these myofunctional therapists are great resources. So I would encourage your parents that are on this, if they're in an area where they're not sure who to go to, seek out a myofunctional therapist, because they're going to be finding someone that's already done the homework for you.
Yep. And we'll put links because Airway Circle, for example, has a great doctor finder, clinician finder that has so many myofunctional therapists that are airway focused, by the way. I mean, they're really walking the walk on that.
Right.
So,
and they've done the due diligence.
A lot of my orthodontic referrals now, guess where they're coming from? Myofunctional therapists.
Yep.
And a lot of them are 3, 4, 5, 6-year-olds. They're early that most orthodontists don't see, but I'm seeing 3 and 4 and 5-year-olds that have sleep apnea that have been diagnosed, and the myofunctional therapist has picked it up, and I've discussed it with the sleep physician, and we're doing different types of expansion early on, and things like that.
It's worth mentioning real briefly that we were going to have a myofunctional therapist on
we
tonight
were
with our panel.
We
Christy Gatto, who was also one of the faculty members. She unfortunately had an unfortunate event of a friend of hers that passed away, so she couldn't. Our thoughts.
But I will be following up with her, so parents will get to hear from her. So I will be doing
so she couldn't join us tonight on short notice, but I would want to make sure people recognize the role that the myofunctional therapists play. And again, if you're having a hard time finding who to go to, the myofunctional therapist has probably already done the homework in your geographical area, and should know who is good. But sometimes they're also frustrated because we're dealing with a specialty that has just it's in its infancy, and there are just not a lot of highly trained clinicians yet throughout the country. But then again, telemedicine is growing, and
I was about to say we have quite a few myofunctional therapists that will do telework. So
as clinicians too, I mean, we're doing a lot of telemedicine. I see patients from around the country.
Which I didn't realize until I talked to Dr. Liao. He works with patients all over the world, and it just I love technology. It's mind blowing.
And we're using it to get this message out. Obviously, this platform is what we're using to get the message out.
To get the message out. So, all right. So the last question, and usually I leave this more as an open question for whoever I'm speaking with, but I want to kind of tailor it a little bit this evening and give you all an opportunity, although it may be the same answer. I'm not sure. But parents that are looking for support for their children, for their sleep and their airway journey, I'll turn it over to each of you for the last word of guidance, encouragement, anything. And I guess, Jatin, let's start with you.
So I found that with my patients, whenever they are having some difficulty, the difficulty looking to them is that they feel alone. They go to their physician, they explain to them I have this and that, and then they're being diagnosed with anxiety or depression or iron anemia or something. And it's none of those things, right? It's sleep. And then they get those procedures, they get on medication, and the problem never goes away. They feel better once they join a community. And that's what I think we're doing here, joining dentists, myofunctional therapists, technologists like myself, parents like yourself. The patients should do the same thing. Patients should join a community. There are multiple Facebook groups, there are LinkedIn groups, there are just communities that you can actually meet in person at the community center just to share your story about what doctor I went to, what lab I went to, what results I did, what therapy worked for me. And just that, even if you don't follow any recommendations, at least you know that you're not alone in the journey.
Yep. And that's great. And I'll make sure that we have a couple like the Airway huddle and there's a tooth pillow one. I'll make sure those are also in the show notes. Rob?
Well, what I would say is the message I'd like to end with for the parents as well is to say that every method of treatment that we have, they all work to some degree, but they are band-aids. They're not cures. The cure is prevention. See, and we're talking about kids here. So the reason I so desperately wanted to do this, Rebecca, is because I want to reach out to these parents and say, you need to pay attention. You need to screen your children yourself. And CSMA, go online. They have great screening forms that we use in our offices. There's a screening tool that a group of us are developing that will allow practitioners to screen, but you can screen. We can help you to look at your children, to be the driving force to maybe prevent the problem, to treat what's happening now, and then prevent them from growing into adults that will only have Band-Aid therapy available for them, unless it's a surgical approach, which, has its pros and cons. So my message would be, we're here to help educate you and help you and push you. And what Jatin said is great, to work in groups and start being the driving force yourself to help your kids, your friends' kids, pay attention. That's my message, and we'll do our best to help you do that.
Thank you. Bill?
Yeah, I think one thing I would, and I kind of build upon what Rob said, is the prevention. And that's where we've got to see these kids early. And a lot of these things are structural, because what happens is they start breathing through the mouth. They can't breathe through the nose. It changes the whole growth pattern of the face. It makes the face narrower. You have a narrow upper jaw and maybe a setback lower jaw. Well, that's a structural issue that orthodontists are supposed to deal with. But a lot of treatment philosophies that we've done, I'm an orthodontist, so I can complain about myself. Okay. and we've had this idea that, hey, all we are just a bunch of estheticians making the teeth pretty. And we're giving them good, pretty smiles, and they can go to the prom and all this other stuff. But seek out an orthodontist or a dentist that understands about airway. Understand yourself, get some knowledge, because you got to have, but a lot of times you'll go, a parent may go to the orthodontist and say, no, I don't want these teeth taken out, or no, I don't want these teeth moved back, or whatever. I mean, there are a lot of things we can do orthodontically to move teeth and bones around all over the place. We can move them forward, we can move them out, we can move them back. Well, when we start moving stuff back, that tends to get involved with the airway. The airway is really nothing. It's a structure that's left over after everything else takes its place. Everything else gets put in position, the tongue, the teeth, the bones, everything. And then the airway is kind of what's left over. But it's like the most important part of the whole thing. Because if you can't, and it's not just that you can breathe. People go, well, I can breathe okay. Well,
Breathe
it's the
properly.
quality and quantity of breath. And unfortunately, with some of the environmental stuff and the Industrial Revolution changed a lot of things. Women aren't breastfeeding like they used to, and that's a problem too. And allergies and all this stuff is a big layer of onion. But as Rob said, the only way you can really cure, and Dr. Christian Gimeno, who was the guy that discovered sleep apnea, especially in children, he said specifically that that sleep apnea in children is a craniofacial growth disorder. And so there's structural changes from an orthodontic standpoint, not the whole thing, but we need to look at seek out oral myofunctional therapists and doctors that understand airway. And believe it or not, David McIntosh, who's a pediatric ENT, he's one of the co-editors of the book we're writing, but he said, just because you're an ENT doesn't mean you know anything about airway. And you would think that all ENTs would, but they focus on different things. It's just like dentistry. If you got an endodontist, they're gonna do root canals or whatever. So I would say, be a little bit wary sometimes. When you go to the orthodontist, it's not all just about straightening teeth and making them look pretty. You want the teeth and the jaws to fit in a certain way that it protects the airway. So ask questions about that. And if you don't get good answers, unfortunately, find somebody else.
I like that.
Jerry said earlier.
Yep. And for parents that haven't heard it, I'll put the link for that as well. Dr. McIntosh was on, I think it was 2022. It's been a while, but it's a 2-part series, and it is an absolute masterclass in airway for any parent that hasn't heard that. So I'll include that. Dave?
Well, I'll just conclude by saying, I think everybody can see at this point that there are many moving parts with sleep apnea, and so there is no one size fits all solution. So I think everybody who's involved with this problem should educate themselves. And I will conclude with once again saying that every AHI should be unpacked, Before we draw conclusions about what should be done, we should ask why it should be done, and we should unpack the AHI in a responsible way. It's a complex system, so we should unpack it responsibly.
And I'll do the shameless promotion for any parent that has not listened to Empowered Sleep Apnea, the podcast. If you can't listen to anything, just listen to season 1. Because we're going to talk about the 5-fingered approach.
Thank you. Yeah, season 1 gives you the vocabulary to navigate this. That's true.
Yep.
Thank you.
So start there. Go get on the island and start. So Dr.
the
Simmons,
Isle of
Sleep. There you go.
Yeah.
So Dr. Simmons, if you would like to close us out with your
Well,
final
thank
thoughts.
you. So I guess, in terms of words of encouragement, the fact that someone's watching this and they're at this point where they're actually hearing my voice, that means they've watched this to its completion. You should be encouraged, because you right now already were exposed to more information than most parents know.
True.
And you're already on the path to getting a solution. And you're probably watching this because you're concerned because you see your child or someone or whatever that's impacted, and you're trying to get more information to enable yourself to seek a solution. And so, we've all mentioned various sources, and CAF, Children's Airway First Foundation, is serving a purpose to get this kind of message out there. And you're not alone, because look, there are people that are giving you this information because we know that these kind of problems are out there, and we're trying to provide the solutions and to create the bridges for the patients to get the care that they need. And you may be geographically situated in an area where there are not many clinicians right now that know very much. Because of telemedicine, you could seek out help elsewhere. You may have to transfer yourself, mobilize yourself to get some kind of testing, or to see some people, to see the dentist that's going to understand. So you may have to, depending on where you live, you may have to, commute a distance, but the care is out there. And so don't give up until you finally feel comfortable with the clinician that can understand your child's problem and can put together a pathway that will improve their health. And you really need to be complimented for your perseverance to even, watching this, podcast or this, this webinar. And there are others that I'm sure you're going to be watching as well. So, congratulations to you, and hopefully you'll be successful in getting the care that you need for your child. And we're here to help.
Yep. And I want to say, I'll close this out on a personal note, because you were all there at the conference, and I said this to all of you there. And so now I will say this here as both a patient that is an airway person. I'm an adult. I'm the reason. I'm an example of, if you can fix it, they don't end up like me. They don't end up like savvy. So, and I'm also a parent. I'm a parent that I didn't know. And now I look back and think, oh, and I'm having to adjust these things in my, my grown children. It's okay. We've all made mistakes. You guys made mistakes. Parents have made mistakes. We didn't know. So start from where you are, put that guilt aside, and trust your parental instincts. Because you know what to do. Trust that mama gut, be that airway mama. And on a personal note, I want to thank each one of you and every one of the luminaries that I am so fortunate enough to talk to. Your passion is infectious. And I thank you so much for what you're doing, because you guys are who are going to save these 400 million children. So thank you.
Well, thank you. Thank you for
Thank
giving us
you.
the opportunity.
It's
Yep.
great. Thanks.
Absolutely.
Thank you.
Great. Okay.